मैं से ढूंढ लूंगी। Very good morning. Very good morning to my dear participants. Welcome to AICTE ATAL FDP Day 2 session. First and foremost, I would like to thank my dynamic Principal Professor Ramaran Adinla encouraging me to apply AICTE ATAL FDP program. Unfortunately, I got opportunity. The CLPT of Pharmaceutical Sciences is the second the college has got AICTE ATAL FDP program in Nagarjuna University. Thank you very much, sir. And also has been providing Zoom Pro since COVID first pandemic, so that we have been organizing so many events, international conference, national conference, Zoom webinars, so that our all family students and B.Pharm students, M.Pharm students are engaging with so many sessions by national international speakers to expose their knowledge. I'm very thankful to the Department of Pharmacy Practice, my colleagues and my dear students, encouraging me to do all these activities. And the participant in the AICTE ATAL FDP program, more than 140 participants has participated in this event. And still, yesterday, day 1 session, even at 4:30, the participants were at more than 98 to 19 members were there. They are so enthusiastic and participating and to knowing the new area, the emergency medicine, very essential to common man and who are in even we are in session, we don't know. We are in the hospital, we are working, we don't know how it is happening. So one should need to know the emergency medicine is required to the common people. So I'm requesting you to all participants and who are joining the session by YouTube or Zoom, please make notes and add key points, so that today the Rakesh Garg sir is a outstanding personality. I can say it's very difficult to read his profile. He's such an extraordinary person we have got. I'm very thankful to Rakesh Garg sir accepting invitation within 5 seconds, 5 minutes. Even by WhatsApp or mail, immediately he has responded, even he is such a busy. I'm very thankful, sir, even you're spending a valuable time with the throughout India. The participants is not from Andhra Pradesh, South India. Throughout India, various participants has participated in this AICTE ATAL FDP program. So I feel such a expertise person in emergency medicine from AIIMS New Delhi is going to give his lecture, and you do make key points and clarify the doubts at the end of the session. Now I would like to invite Rajeshwari, 5th Form student, to read the profile of Rakesh Garg sir. Welcome you all. Please unmute. I am requesting you all participate. Please mute your audio or video while session is going on. Please cooperate. And one more important thing, as for AICTE ATAL FDP program, we know that we need to have 80% attendance and 60% marks should get. So that we need to have some key points to give feedback and exam. There will be small test will be there. Every day we are keeping. Thank you very much, sir. Thank you, Principal sir. So now I would like to invite Rajesh to read the profile of Rakesh Garg sir. Thank you one and all.
A very warm good morning to everyone. Now I am going to read the profile of Dr. Rakesh Garg sir, MD. Sir has done MD in Anesthesiology Senior Residency in AIIMS, New Delhi. Sir is now working as additional professor in anesthesiology, critical care, pain and palliative medicine, AIIMS, New Delhi, India. And also sir has a total of 250 publications, both international and national. And also sir has all the 25 chapters in a book and also editor of 2 books. Now sir is a secretary of Indian Society of Anesthesiology, Delhi. Sir is a council member of ISSP Delhi chapter. And sir is also an executive member in RSACP. Sir is a vice president of AIDDA. Sir is the editor of PubMed Index Journals. Sir is the editor-in-chief of Journal of Anesthesiology and Clinical Pharmacology. Sir is the editorial board member of 12 international and national journals. And also, sir is a core member for the formulation of guidelines like IRC, CRS, HIPEC, SOPC, and ISA NALS. And also, sir is a member and formulation of many guidelines like many associations. Sir has bagged many awards, both international and national awards. Sir has bagged 2018 Albert Nelson Marquis Lifetime Achievement Award by WHO. Sir has bagged Pablon's Peer Review Award in 2017 for outstanding performance for review of manuscripts. Sir has bagged ISA Proficiency Award in 2019. Sir has bagged ISA Bhopal Award 2018 for academic excellence. Sir has elected as top 100 health professionals 2017 by IBC Cambridge in England. Sir has received Outstanding Scientist Award for contribution and achievement in anesthesiology. Sir has bagged second prize for SMG Best Research Paper Award in 2011. And also sir has many publications and papers. Thanking you, sir, for giving me this opportunity for reading your profile.
Welcome to session.
Today we are going to discuss about the cardiopulmonary resuscitation guidelines. This is one of the very essential skills that we need to understand and follow in our clinical practice, because this will give an optimal outcome. We have to understand the integrities of the various approaches and steps for CPR for animation, so that the outcome becomes very, very important. The basic consideration, the Indian Resuscitation Council has developed its own guidelines which are very much suitable for Indian subcontinent, and this was under the aegis of Indian Society of Anesthesiologists. The Indian Resuscitation Council has given 3 guidelines for different place and different person depending upon the clinic they have. So the first guideline they have support CLPT, which is primarily for the lay person, because you want that lay person should also be involved in resuscitation, so that any patient of cardiac arrest can get immediate care and the outcome becomes much better. For the basic cardiopulmonary life support, PCLS, which is again for paramedics and medics from outside the hospital. We understand that outside the hospital, the infrastructure may not be as robust as inside the hospital. So even for our paramedics, they have to perform CPR in a illustrated manner. So this is the guideline which is suitably applicable in this scenario also. The third guideline is the comprehensive cardiopulmonary support. We need a single dedicated guideline which will be able to manage CPR if it happens inside the hospital. Since inside the hospital, we expect the people are trained. So this CCLS will help us help the patient to have an optimal outcome. So these are the three guidelines which have been formulated by Indian Resuscitation Council. And in this session, we will discuss about a comprehensive cardiopulmonary life support. When we talk about resuscitation for any patients, we need to understand its evidence. We need to understand 70 million health of anesthesia, wherein these guidelines can be downloaded. And anybody who is interested to know about the evidence or the genesis of these guidelines, all the details are available in this manuscript, which can be downloaded free of charge from the website of Indian Health of Anesthesia. Resuscitation. The private thing is that we have to understand some focus points. These focus points will be practical to improve the outcome of overall cardiac arrest. So when we talk about the optimal outcome of a patient with cardiac arrest, it will be these legs that we are talking about. And for CCLS, we have 5 essential core legs that needs to be understood. Now these are the there will be some realizations that will be for the cardiac arrest occurs. So we have to recognize situations, this condition, so that the cardiac arrest we have to manage this patient at the earliest. Cardiac arrest beyond. So this is the second link, which is early recognition and activation of code review. The third link is we have to start the early high quality CPR. Yes, CPR, but we have so this is the earliest without wasting some time, without wasting any time. Comprehensive life support and post-resuscitation space. We have to integrate the other advanced aspects, which could be the use of drugs, the airway equipment techniques, and other the quality of CPR. So this has to be integrated, and this is the important aspect for the CCLS as once we have prevented the patient of the return of cardiac circulation happens, the post-resuscitation care also needs to be provided. While some intervention, for example, a patient of are in this hospital. We can observe a person who suddenly somebody your team and you have to fulfill this mission. At times it can happen in the hospital person also. So in those situations, we have mission. This is the algorithmic approach, that way approach, which has been developed for CCLS and discussed it one by one. Starting for initiating CPR, safety of but sometimes the patient may get an cardiac arrest, example, or some unsafe place in the vicinity of the hospital where the situation of CPR may not be appropriate. In this situation, we should ensure that the patient CPR once the CPR shows the check is possible to be but this check is possible from facing the patient. So by these standards, see for the patient responsiveness, response or show some purposeful movement. This means the patient will be responsive. So this means the other one is not responsive. In case the patient is responsive, in that situation, you just have to monitor the patient. Obviously, if the patient has
Participants kindly requesting mute your mic. So session is getting disturbed. Please do understand and support. Thank you.
some underlying etiology for this. So assess the cause and manage them accordingly. So this patient needs to be monitored somewhere inside the hospital where you can assess what will the management and subsequently this patient. This patient is not responsive, is not showing any verbal communication, any verbal words, or they are not having any purposeful movement. only for the layperson, because you want the layperson to also be involved in resuscitation, so that any patient will be much better. We need to understand that outside the hospital, the infrastructure may not be as robust. So even for a trained paramedics, they have to perform CPR in a restricted manner. So this is the guideline which is suitably applicable at this scenario also. The third guideline is the comprehensive cardiopulmonary life support. We need a single dedicated guideline which will be able to manage CPR if it happens inside the hospital. Since inside the hospital, we expect the people are trained. So this CCLS algorithm will help us and help the patient to have an optimal outcome. So these are the three guidelines which have been formulated by the Indian Resuscitation Council. And in this session, we will discuss about the comprehensive cardiopulmonary life support. When we talk about the cardiopulmonary resuscitation for any patients, we need to understand its evidence. We need to understand that how these guidelines have been developed. Now, this is the manuscript which has been published in November issue of 2017.
Yes, sir.
That should be understood. Now, these are the focus aspects that need to be taken care of when anybody is being managed for cardiac arrest. And these 5 links include, for CCLS includes various aspects. We'll discuss one by one. The first core link is the early recognition and management of pre-arrest condition. Support COLS, which is primarily for the layperson, because we want that layperson should also be involved in resuscitation so that aspects we'll discuss one by one. The first core link is the early recognition and management of pre-arrest condition. What does it mean? That whenever the cardiac arrest happens, there will be some pre-arrest situations that will be happening before the cardiac arrest occurs. So we have to recognize these situations, these conditions, so that the cardiac arrest does not happen. So that's why it becomes very, very important to recognize and manage these pre-arrest conditions to prevent the cardiac arrest. But in certain situations, as we see the second link, the second situation, if cardiac arrest happens, we need to recognize it at the earliest, because as we will discuss little later, we have to manage this patient at the earliest. With each minute delay in the cardiac arrest, the outcome further decreases. So that's why we have to early recognition of the cardiac arrest, and definitely we need some help. That's why the activation of the team who is involved into management of a cardiac arrested victim needs to be activated. Usually it is nomenclatured as Code Blue team, but it could be variously named in various hospitals. So whatever the team is which is responsible for management of cardiac arrest victims, they need to be activated. So this is the second link, which is early recognition and activation of Code Blue. The third link is we have to start the early high quality CPR.
Yes, we have to start the CPR, but we have to maintain the quality of CPR also, the effectivity of the CPR, so that the outcomes becomes much optimal. So this has to be done at the earliest without wasting some time, without wasting any time for initiating the CPR. As we know that in adult patients, the majority of time, the cardiac arrest happens because of cardiac cause. And the treatment for these type of arrhythmias, which happens in this cardiac cause, is the early defibrillation. So whenever we start early high quality CPR, the defibrillation should be integrated into this CPR at the earliest. So whenever it is available, we should initiate the process of defibrillation so that the arrhythmias can be returned to normal sinus rhythm and the outcome becomes much better. And the final link that you see here is the early comprehensive life support and post-resuscitation care. This means we have to integrate the other advanced aspects, which could be the use of drugs, the airway equipment techniques, and other modalities of monitoring the quality of CPR. So this has to be integrated, and this is the important aspect for the CCLS as well. Once we have revived the patient, once the return of spontaneous circulation happens, the post-resuscitation care also needs to be provided to the patient, because the underlying etiology which we have diagnosed may require some intervention. For example, a patient of MI, patient of heart attack with myocardial infarction, probably will require some cardiology intervention, may require some amount of angiography or angioplasty. So this patient has to be shifted to the cath lab at the earliest so that the underlying etiology can be managed. So these are the 5 links that needs to be taken care of. And these are the core themes, core links that will help us to have a good optimal outcome of a patient with cardiac arrest. Now, how to translate these 5 links into an algorithmic approach, in a stepwise approach, this needs to be understood. So now this could be the situation when we are in this hospital. We can observe a person who suddenly collapsed in front of you. You can also see somebody is already collapsed and you have been summoned there for help. Maybe you are a part of code beauty and you have to further manage this patient. At times it can happen, a collapsed patient is brought inside the hospital, maybe by a trained person or maybe by the lay person also. So in those situations, in all these 3 situations, we have to manage the patient. Now, this is the algorithmic approach, step-by approach, which has been developed for CCLS, and we'll discuss it one by one. Now, the first aspect for starting or initiating CPR is the safety of the place where you're doing CPR. Usually inside the hospital, the place is usually safe, but sometimes the patient may get in cardiac arrest in some corridor or maybe in some unsafe place in the vicinity of the hospital where the situation to start CPR may not be appropriate. In this situation, we should ensure that the victim, the patient, is shifted to a safe place so that we can give an optimal CPR for these patients. Once the safety of the place has been ensured, we have to check the response of the victim. Now, this check response should be done from facing the patient from front. We have to tap on the shoulder, as you can see in this picture. And while you're tapping on the shoulder, you have to speak loudly also. And you can speak in a language which patient can understand. For example, say, hello, are you all right? So whatever language you want to use depends upon the patient's understanding. So this means you're checking for the response using tactile as well as verbal response. So by these 2 methods, you can see for the patient responsiveness. In case if a patient has some verbal response or shows some purposeful movement, this means the patient would be responsive. So this means checking response will give us 2 options. One is responsive, the other one is non-responsive. In case the patient is responsive, in that situation, you just have to monitor the patient. And obviously, if a patient have loss of consciousness for some duration, this means there could be some underlying etiology for this. So assess the cause and manage them accordingly. So this patient needs to be monitored somewhere inside the hospital wherein you can assess for further management, and subsequently, depending upon whatever the underlying etiology is, a specific intervention can be provided to this patient. In case patient is not responsive, he is not showing any verbal communication, any verbal words, or they are not having any purposeful movement, in that situation, you need some help. You need to activate the code view team, or it could be the local team. So whenever we activate the code view team, remember, you need to get a defibrillator. As I mentioned earlier, that defibrillation is one of the core aspects, and it needs to be delivered at the earliest for a patient with cardiac cause, which leads to a cardiac arrest. And obviously, you will also be looking for a crash cart, which will have drugs and other airway equipments that will be required when you start the CCLS. Now, once the activation of code blue has been done, you have to check for the breathing and the pulse. Remember, as in this photograph, you can see that the pulse and the breathing both needs to be checked simultaneously. And also remember that both the things needs to be done within 5 to 10 seconds. You should not take more than 10 seconds for checking breathing while palpating the carotid pulse. The carotid pulse needs to be located into the thyroid prominence, as you can see in this picture also. And locate the thyroid prominence and the trachea using your 2 fingers, preferably on the same side on which you are sitting. Slide into the groove between the trachea and the neck muscles and try to palpate for pulse while looking towards the chest and the abdomen for breathing movements. As I mentioned earlier, you have to check it for 5 to 10 seconds. So you can chant loudly as 1001, 1002, 1003 till 1010. So this will give you an approximately timing also while you are palpating for the pulse and checking for the breathing as well. Now, once you have checked for the breathing and pulse, 3 situations can happen. These 3 situations, you have to manage them accordingly. The first situation would be the patient is having normal breathing with definite carotid pulse. Now, I use a word here, definite carotid pulse, because the pulse sometimes may be equivocal. We are not very sure that the pulse is palpable or not. So we have to confirm until unless we are sure that the pulse is present, then only consider it to be a present carotid pulse. Otherwise, assume the pulse is not present. So in the first situation, if we have a normal breathing with definite carotid pulse, these patients need to be reassessed every 2 minutes. And then you have to look for the underlying cause, that why a patient has become non-responsive, and manage them accordingly, whatever the etiological factors come based on your assessment. This assessment could be the history, the physical examination, the relevant investigations that needs to be done, and based on those findings, you can manage the patient subsequently. The second situation could be there is abnormal or no breathing, but there is definite carotid pulse. So this means this is a situation wherein the patient has gotten respiratory arrest. So here the respiration needs to be supported, the breathing needs to be supported here. So for this situation, you have to provide 1 breath every 5 seconds. So this means approximately 12 breaths per minute. Since the patient is inside the hospital, we advocate the use of bag and mask ventilation for the provision of breath for these patients. But since the patient is not breathing, there could be some underlying etiology. Maybe patient is in sepsis, maybe patient is having an impact of some drug overdoses, which leads to respiratory arrest. So whatever the situation is, as I mentioned earlier, you have to look for the history, the examination, the imaging, and the investigations. Based on this, you have to manage them accordingly so that the patient can be revived, the respiration can be revived, and the patient can be shifted further on. When we talk of the breath, as I mentioned earlier, we have to use bag and mask ventilation. 1 breath needs to be delivered every 5 seconds, so approximately 12 breaths per minute. Remember, each breath should be delivered over 1 second. You can chant 1001 for this 1 second, as we mentioned earlier. And the tidal volume should be a normal tidal volume. We should not be hyperventilating patients with regards to the number of breaths or the tidal volume. And the endpoint for breath would be a visible chest rise. So when you give a normal tidal volume and you can see a visible chest rise, so that should be the endpoint when you provide breath for these patients. In case, when you assess them every 2 minutes, in case the breathing is optimal now, patient is breathing now, having a normal breathing, in that situation, as we mentioned earlier, you need to reassess these patients, look for the underlying etiology, monitor the patients, and manage them accordingly. The third situation could be wherein there is abnormal or no breathing without carotid pulse, without definite carotid pulse. So this means the breathing is also absent, the pulse is also absent. So this is a cardiopulmonary arrest. In this situation, we have to provide cycles of 30 chest compressions and 2 breaths. So this cycles of 30 chest compression and 2 breaths needs to be repeated 5 times. Now, these compressions will be having some quality that we need to understand, and the breath also needs to be delivered in a cycle form, especially in situations where patient is not having some definite airway already in situ, which can happen sometimes in ICU care. So in case if some definitive airway is already there, we'll discuss a little later how to manage these patients. For effective chest compression, we have to identify these 4 components. We have to identify the appropriate rescuer position, identify the site of chest compression, the placement of hands, and then we need to initiate the process of chest compression. The chest compression needs to be done in a surface which is hard one. At times it can happen there is a soft mattress. The chest compression may not be very effective in those situations. So try to shift the patient onto a hard surface if they are not already on the hard surface. Sometimes if you are using bed, we can insert some hard surface or some wooden surface just below the patient so that the surface becomes hard and effective chest compression can be given to the patient. The rescuer position, the chest compression can be done from either side, so there is no sidedness for starting the chest compression. Try to kneel beside the victim. Sometimes if patient is on bed, you can just climb on the bed so that you are kneeling just beside the victim, or you can use a footstool. Remember that when you kneel beside the victim or use a footstool, your waist of the rescuer should be above the patient, and this is required for providing an effective chest compression. Once you have placed yourself, you have to identify the lowest end of xiphoid process, as we can see in this picture. Now keep 2 fingers above the xiphoid process and then subsequently keep heel of other hand above it. Now this will be identifying the correct location wherein you have to start your chest compression. So once you have identified the chest compression and place one hand, keep the other heel of the other hand over the first one and interlock fingers, as we can see in this photograph as well. So now this will be the correct placement of the hands. Your fingers should not be touching the chest. It is only the heel which remains in the center of the chest which is touching the chest. So just to revise once more, if you see in this picture, you have to identify the lowest end of the xiphoid process. Subsequently, keep 2 fingers at the lowest end of xiphoid process. Keep the heel of the one hand above the 2 fingers and the other hand over the first hand so that your heel is touching the chest. Fingers are interlocked and they are not touching the chest. Now, once you have identified the position, you have to position yourself in such a way that the shoulder, the elbow, and the wrist all are in straight line. So this is very, very essential so that you can provide an effective chest compression. The chest compression should be compressed at least 5 to 6 centimeters. That should be the depth of the chest compression. The speed of the chest compression should be 120 times per minute. And remember, when you are compressing the chest required should also be sufficient. This is essential because when we compress the chest, we have to release it also so that the venous return comes and fills into the heart so that the cardiac output is increased. But remember, when you're providing the chest required, your hand must not be lifted from the chest because in this situation, the placement of the hand may get disturbed. Also remember that the chest compressions must not be stopped unnecessarily because the paramount, one of the important aspects for patient with cardiac arrest is the good quality effective chest compression. So if you stop it, the outcome may deteriorate further on. Now, since we said that the compression speed should be 120 times per minute, and it should be done in sets of 30 chest compressions followed by 2 breaths. So it will be a good idea if you can chant loudly as 1, 2, 3, 4 till 30. So this will just not only maintain the speed, but you will also be able to replicate those 5 cycles of 30 chest compression. And the other person who is helping for the breath will be ready when you are just completing 30 chest compressions so that the interruption in the chest compressions are kept minimal. We also know that the chest compression leads to a lot of fatigue. The effectivity or the quality of chest compression deteriorates with time. So if there are more than one person, you can interchange every 5 cycles so that good quality chest compression can be provided to these victims. Now, once the 30 chest compressions has been provided, now it's a time to provide 2 breaths. So when we talk of the 2 breaths, there are 2 components of it. One is maintenance of a patent airway, and the other one is the provision of the delivery of the breath. So when we talk of the maintenance of patent airway, which is essential to deliver the breath into the lungs, we can have 2 techniques. One is head tilt and jaw lift, and the second technique is jaw thrust. The head tilt and chin lift can be done in all patients who are not having any suspicion of neck trauma or cervical spine injury. In this situation, as you can see in this picture, you can keep 2 fingers over the chin and the other hand over the forehead. And by using these 2 hands, you can just not only do the chin lift, but also tilt the head so that the tongue is lifted up from the oral cavity and it remains patent. So this will open up the airway. Now, in case if you have any suspicious of cervical spine fracture, they must not be unhatted because it can lead to more injury to the cervical spine, and subsequently there could be a neurological deficit. So what we can do in this situation for opening up the airway, you have to do jaw thrust. As you can see in this picture, we can just do a jaw thrust to open the airway. But remember, simultaneously, if you have an extra rescuer, try to provide manual spinal motion restriction, which is also known as manual inline stabilization. This will prevent any subsequent mobility or motion at the cervical spine, and the chances of injury would be further reduced. Now, once you have maintained the airway, the patency of the airway has been assured, you have to deliver the breath. We said that the breathing inside the hospital should be delivered using bag and mask ventilation, which should be connected to an oxygen preferably, and oxygen should be flowing at high flow. So once you have started using bag and mask ventilation, you have to provide 2 breaths. Each breath should be over 1 second, and there should be a pause of 1 second after the first breath only for the expiration to happen. Do not interrupt chest compression unnecessarily. Moment you have given the second breath, don't wait for the expiration because it's a passive process. Immediately start the chest compression. And as I mentioned earlier, the endpoint for breathing remains a visible chest rise. We must not hyperventilate the patient because it can deteriorate the patient's condition. There's a risk of gastric insufflation, and there could be a risk of regurgitation and aspiration. Also, with increased intrathoracic pressure, there could be decrease in the venous return. So what should be the endpoint for this situation? It should be just the visible chest rise, and normal tidal volume breath should be delivered for this visible chest rise. Now, once we have given 5 cycles of 30 chest compressions and 2 breaths, we need to do the pulse check again. We have to check for the carotid pulse as we have mentioned earlier, and this pulse check should be done for 5 to 10 seconds. Now, in this situation, 2 options can be there. When we check for the pulse, either the pulse is present or the pulse is absent. So in case the pulse is present, this means the patient has return of spontaneous circulation. The next step would be checking for the breathing also. So as we have already explained earlier, now in this situation, you have to provide 1 breath every 5 seconds using bag and mask ventilation, and reassess every 2 minutes whether the breathing has been resumed or not. Look for the underlying cause and try to manage it. In situation wherein the respiration is also having, there is already an optimal breathing movements, in that situation, you can reassess every 2 minutes and look for the underlying cause and manage. The other option could be the absence of pulse when you have checked for the carotid pulse. In this situation, if the pulse is absent, then you have to start 5 cycles again, which includes 30 chest compressions and 2 breaths 5 times again. Now, this cycle will continue till you have further equipments available to you. Since you have already called for help, the Code Blue team has been activated. You have already summoned someone to get you the defibrillation and the crash cart, which have airways, which have drugs that will be required for further management. So till then, you have to continue the 5 cycles of 30 chest compressions and 2 breaths, followed by checking for carotid pulse. And subsequently, as we have just discussed, you have to take this step depending whether the pulse is present or the pulse is absent. The moment the defibrillator becomes available to you, you have to initiate the further process. Now, whenever the defib comes to you, you don't have to wait for the completion of these cycles, 5 cycles of 30 chest compression and 2 breaths. Whenever it becomes available, you have to attach it immediately and analyze the rhythm for further management. Now, when we said of defibrillation, there could be 2 options with the defibrillator. Some of the defibrillators are available with pads, and some of the defibrillators have the pedals. So depending on whatever the defibrillator have, if it is having pads, which is stickable pads, you can attach on the chest and analyze the rhythm. In case there are pedals, you can put the pedals on the chest to analyze the rhythm. But remember, while you are attaching the pads, do not stop chest compression. At that moment of time, the chest compression should continue. And once you have placed the pads or the pedals, at this point of time, you have to interrupt the chest compression because the chest compression could create artifacts. So at this point, just stop the chest compressions and analyze the rhythm, that what type of rhythm is, whether you need to deliver shock or they are not shockable rhythms. So in this situation, once you have attached and analyzed the rhythm, these 2 options can happen, as you can see, the shockable rhythm versus not shockable rhythm. So now the shockable rhythms would be the ventricular fibrillation and the pulseless ventricular tachycardia. The non-shockable rhythms would be asystole and pulseless electrical activity. Also remember, sometimes we see a asystole, so you have to follow this flatline protocol, because at times, because of the equipment itself, there can be a flat line. So you have to follow this flatline protocol, check that whether the ECG leads are actually attached to the patient, the cable is attached to the monitor. You can increase the gain or the size or the amplitude of the ECG on the monitor so that the gain is optimized. Is the selection of lead proper? Sometimes it can happen that we have attached the lead of the defibrillator for ECG monitoring, but the defibrillator may be on the pedal mode, so it may not pick up until the pedal is attached. So look for the lead selection. Sometimes it can be a fine VF, so you have to increase the size of the ECG so that you can see whether it is actually VF or it is a flat line, that is the asystole. So once you have looked for all those causes, then only you label the patient as asystole. So once you have taken a decision that it is shockable versus not shockable rhythm, in case it is shockable rhythm, that is the VF or pulseless ventricular tachycardia, in that situation give one shock. In defibrillation, you have to start with 120 joules and you can escalate further the subsequent shock every after 5 cycles to 200 joules. Sometimes there could be the availability of AED. So in case if AED is you are using, it will be auto-selected joules and you can deliver the shock. Once you have given the shock, you don't need to check for something else or the response of the check. You have to resume 5 cycles of 30 chest compressions and 2 breaths again. And when you're providing this 30 chest compressions and 2 breaths, you have to ensure to provide high quality CPR that we have just discussed. That what do we mean by the high quality chest compression and the breath. In situation, if the rhythm is not shockable, no shock is provided to the patient, resume CPR and provide 5 cycles of 30 chest compressions and 2 breaths. After 5 cycles of 30 chest compression and 2 breaths, you have to look for the rhythm again. Now, depending upon the rhythm, you can take a decision whether it is shockable or not shockable. If it is shockable, you can deliver 1 shock. The energies can be escalated in subsequent shock which is being delivered by the defibrillator. And in case it is not shockable, you have to resume CPR again. Now, these cycles will go on. And since you have already asked for the further help in the form of crash cart, there could be equipments or the drugs or the cannulation that will be available to you. So you have to perform the venous access, the airway management, drugs including anti-arrhythmics, and looking for the cause simultaneously while the cycles of CPR is being done. So let's talk of the venous access. When we talk of the venous access, the peripheral venous access is the preferred one. So when you use this intravenous route, you can give the drugs as boluses. We'll discuss what are the drugs that needs to be delivered. But remember, since the circulation is not existing, you have to give 20 ml bolus of IV fluid, and you can elevate the extremity for 10 to 20 seconds so that the drugs can be shifted from periphery to the heart. And on the heart, we are already doing a chest compression. The drug will be distributed to the receptor organs. In case if you are not able to secure intravenous access in 2 to 3 attempts, now it's a situation we can think of the second preferred mode. And the second preferred mode is the intraosseous route. Even in the adults, we can use the intraosseous route. Tibial, upper end of tibia could be the preferred site. And you can give the drug as you give for the intravenous route in the same dosages, in the same volume. Now, in a very extreme situation, if you are not able to secure the intravenous access or the intraosseous route, and if the patient is already having an endotracheal route, you can use some of the drugs via endotracheal route also. And these includes naloxone, atropine, epinephrine, and lidocaine with regards to the CPR. But remember, when we want to give the drugs through endotracheal route, the drug dose has to be increased, and it is usually 2 to 2.5 times the dose that we give for the intravenous route. You need to dilute into 5 to 10 ml of normal saline, give it to the endotracheal route, and continue using ventilation, and the drugs will be absorbed from the tracheal mucosa or the alveolar mucosa. Now, when we talk of the airway management, in the airway management, you can secure the endotracheal tube. But remember, the chest compression should not be unnecessarily interrupted for securing the airway. In case, if you are happy with the ventilation, with bag and mask ventilation, continue. In case the expertise are available, which will be able to secure the endotracheal route through the airway, then endotracheal route can be secured. A definitive airway can be secured. Now, once the definitive airway has been secured, so we were talking about the cycles of 30 chest compression and 2 ventilation. But once a definitive airway is already there, in that situation, the cycles will not more will be there for CPR. You have to continue chest compression at the speed of 120 compressions per minute and give one breath every 6 seconds. That is around 10 breaths. So that needs to be continued once the airway has been secured. Now coming to the drugs, we have to think of certain drugs which are being administered during the CPR. The most important drugs remains the adrenaline, which is also known as epinephrine. You have to give 1 milligram of the adrenaline to these patients. Now 1 ampule of adrenaline contains 1 ml of solution, which contains 1 milligram of adrenaline. That needs to be diluted into 10 ml, and that can be delivered as boluses. And preferably it should be given while the chest compression is ongoing. It can be repeated every 3 to 5 minutes, depending upon the patient's response. Now, since the patient is already having arrhythmias, and if patient is not having return of spontaneous circulation with the initial defibrillation attempts, now it's a time to start them on anti-arrhythmics. So after initial 2 to 3 sets of 5 cycles of CPR, if the arrhythmias persist, then start thinking of anti-arrhythmic drugs. The first choice of drugs to control arrhythmia remains the amiodarone. Now, amiodarone needs to be given as 300 milligram as bolus, slow bolus, and if required, you can repeat the second dose, and second dose would be 150 milligram if the arrhythmias persist. In situations, if the amiodarone is not available, you can use the second choice drug, which is lidocaine. But remember, this is an alternate drug to amiodarone with persistent arrhythmias. As we mentioned earlier, that CPR is not the definitive treatment for cardiac arrest, but rather it means maintaining respiration and circulation until the underlying etiology is being assessed and can be corrected. So when we are providing CPR to some patients, we have to look for the reversible causes. Now, this reversible causes, we have to assess that why did this patient develop symptoms or arrest, and is there a reversible cause that can be treated while performing CPR? So you have to search, find, and treat these reversible causes so that the patient outcomes becomes much better. Now, if you see the Indian scenario or Indian subcontinent, there are many factors that can lead to cardiac arrest. And this mnemonic, hit the target, will be the mnemonic that you can easily remember. The H stands for hypoxia, that can happen because of any chest conditions, any lung condition. The I stands for the acidosis, increased H ions. T stands for tension pneumothorax. The second T stands for toxins or poisons or drug toxicity. The H stands for hypovolemia, that can happen because of many medical and surgical conditions. E stands for electrolyte imbalance, which can be potassium imbalance, hypo or hyperkalemia. The T of target stands for cardiac tamponade, that can happen in situations of trauma. A stands for the acute coronary syndrome, which is one of the commoner regions. R stands for raised intracranial pressure, which could be the subarachnoid hemorrhage. That can happen in case of the hypertensive emergencies, or can also happen in case of trauma. G stands for glucose, the hypo or hyperglycemia. E stands for embolism, that is pulmonary thrombosis. And the T stands for the temperature fluctuation, primarily the hypothermia, which can lead to cardiac arrest. So while we are doing CPR, we have to remember these causes. We have to assess these causes using various modalities. That is, the reviewing the history, looking for the examination findings, the investigations, and the imaging, that you can do it while the CPR is ongoing and try to correct them. So you have to have history, physical examination, and review the medical record, and review from the patient attendance also at times. So based on findings, you can think of suitable investigations. For example, you can send the blood samples for electrolyte imbalance, for sugar. You can look for the ultrasound findings, which can give you a finding of any collection of blood in the abdomen that can lead to hypovolemia. So based on this, you can look for suitable investigations or imaging, and that should be done while the CPR is ongoing. The chest compression must not be stopped while you are assessing for all these factors, and the resuscitation process should continue while assessing for the cause of cardiac arrest. Also remember that the high quality CCLS must be maintained. It's just not the steps which we have just enumerated, but it is the high quality of various parameters that must be maintained. And the emphasis must be there on the continued quality check. So if you have team members available with you, then the quality check should be done by the team members intermittently, and the response should be given so that the quality of CPR can be maintained. Now, there are various aspects that would enhance the outcome. And that is what we are talking of, the quality assurance here. The first that we need to look for is the chest compression. We have already discussed that chest compression speed, rate, and required. That needs to be maintained. Ensure a chest compression speed of 120 compressions per minute to a depth of 5 to 6 centimeter. Allow complete chest recoil between compressions without lifting your hand from the chest. Do not stop chest compression unnecessarily while you are applying the monitors or the pads or giving the drugs or securing the intravenous access. At any point of time, the chest compression should continue. With regards to ventilation and airway, do not unnecessarily interrupt chest compression for securing the airway. Do not hyperventilate. We have already mentioned that the endpoint of ventilation is visible chest rise. So a normal tidal volume breath is sufficient to look for the visible chest rise. Now, in certain situations, when we are inside the hospital, there could be certain other monitoring equipments available to us. The monitoring of the end-tidal capnography is a good tool for quality assurance. If on capno you see that the values are less than 10 millimeter of mercury, then the quality of chest compression is inadequate. This means you have to provide more effective chest compression for these patients. If the intra-arterial pressure is already available, and you can monitor it. And if the relaxation phase pressure, that is the diastolic pressure, is less than 20 millimeter mercury, it again indicates that the chest compression is not appropriate. You have to further improve the chest compression. So these are the feedbacks that can be given while the CPR is being ongoing by the team members, so that you can provide good quality CPR and the outcome may become much better. Now, once the patient is revived with signs of circulation, then you can shift the patient for post-resuscitation care. Post-resuscitation care will lead to continued management of the underlying etiology. Maybe the patient requires dialysis, maybe the patient requires electrolyte management, maybe the patient requires some amount of coronary intervention. So depending upon the assessment, the post-resuscitation care would also include for this, so that the patient may not have re-cardiac arrest again because the underlying etiology has not been taken care of. Now, we need to remember about the team dynamics. Now, I was mentioning earlier that while we are doing CCLS, we have to talk of various team members because we have to do multiple steps. Somebody will be doing a chest compression, somebody is doing a airway management, somebody is providing breath, somebody will be giving drugs and other monitoring aspects. So this means we have to have good dynamics for an optimal outcome of the patient. So the effective resuscitation is synonymous with good teamwork. So we have to work as a team, and this team would require just not the skills, but a good communication between the team leader and team members, and that will lead to an optimal outcome. Now, when we do a CCLS for a patient, we can position ourselves accordingly so that all work are being carried uninterruptedly. So this picture, you can see that how the various members of CCLS can locate themselves so that the care of the patient can be given optimally to these patients. Also, when we talk of team dynamics, we have to follow certain core concepts. So when the team members are there and somebody has become a team leader, who can be anybody who has seen for the first time for the patient and is knowledgeable about the resuscitation aspect, that each member should have specific task assignments. So if somebody has to do a chest compression, so that specific assignment must be given to this patient. But we need to remember that the team member has some strength and weaknesses. So we should be exploring the strength of the team member to assign a particular task to them. We should not having crosstalk between them. One team member should communicate with the team leader so that we can have a closed loop communication between the team members and the team dynamics is maintained. It should be a clear and direct delegation of the message. If you want to give some drugs or give some information or task to a team member, the message should be very clear and directed. It should be directed to the person concerned and it should be clear. There should be constructive inputs. If some of the team members are missing something, the constructive inputs can be given while the CPR is being ongoing. Have a mutual respect for team members. And once the CCLS steps has been followed and the outcome of the patient is being observed, a patient has been shifted to post-resuscitation care, we can have debriefing. Now, this debriefing is very, very essential and one of the core aspects of team dynamics, wherein we summarize and evaluate the outcome. If there are certain missing links, we can re-explore them. If some of us is having some limitation in some skill aspects or communication gap, that can again be thought of and discussed during the debriefing session. We can understand the limitation and update the skill and knowledge based on this debriefing session. And this will obviously help us to improve ourselves in subsequent provision of resuscitation for any victim. We need to understand limitations and improve the system in case if during this CCLS something has been lacking during the process of CCLS. So this is the whole approach of management of the CCLS for patients who gets in cardiac arrest inside the hospital. In case if you want more information, this is our website, www.cprindia.in, wherein you can see all the algorithms and other information which are related to the CPR, CCLS as well, and they can be downloaded from here for further information. If you have any queries or feedback, please do communicate with us. Thank you so much.
Hello. Am I audible, sir? I'm not able to hear you, sir.
So it's audible, sir.
Right. Thank you. Thank you so much. If there are any questions or queries, I think we can take up the questions if somebody wants to ask any queries or any questions.
Yeah. Yeah, participant, please do ask questions. Even Saad doesn't have time, but even
So I think we have tried to discuss the various concept of resuscitation, and this being a teamwork, as I mentioned in last couple of slides, the role of everybody in the team is equally very important to have a good outcome. So whether it regards the good quality or the identification or identifying the cause, sending sample, everybody is assigned some role when you work as a team. As I mentioned, 4 to 5 people will be a part of team, and they have to at times reverse their role during the CPR process. Now, in addition to this, what I just want to show you, because many of you will be helping the layman also to the learning and teaching and training. So when you ask about the teaching and training for the layperson, we are not teaching them this complicated CCLS to the laypersons. So for the laypersons, we have different Garg, which is labeled as compression on support, when we give more emphasis on the chest compressions. So the events are little abridged from what I have just mentioned in my slides. Herein, you need to check for the response, and if the patient is not showing response, you need to call for help, and then subsequently start good quality chest compression. The chest compression remains, the parameters for good quality chest compression remains the same, which I have just mentioned you in my slides of CCLS. and they have to continue this chest compression 30 cycles, 30 times, 5 cycles, and then they need to reassess it. And this will continue till they get some help from the expert medical personnel when they have called for help. So I will suggest.
Good morning, sir.
Yeah, good morning.
Sir, the patients are dying as a main risk factor of cardiac arrest these days. We know some of the risk factors are like cardiac diseases and sometimes obesity and gender may vary. But without having some risk factors, also patients are dying with cardiac arrest. What might be the reason for having cardiac arrest without having any risk factors?
Can you repeat the question, please? I was not able to hear properly. Can you just repeat it once?
Yes, sir. So generally these days patients are dying with cardiac arrest.
Mm-hmm.
So the patients are may having risk factors of cardiopulmonary diseases and some of the family history too. But some people are dying without any risk factors with cardiac arrest. So what might be the reason for this, sir?
No, actually, this may not be absolutely correct that they don't have risk factors or underlying cardiac disease. Usually they are cardiac disease. So sometimes it happens that they are not identified timely, or patients may be ignoring those symptoms. So they must be having something. There sometimes happens that one of the most common ignorance is people assume the chest pain due to cardiac disease has gastritis, right? Acidity, and they take the drugs for acidity only. But in fact, because the cardiac symptoms can mimic or they have similar symptoms as the other disease. As I just mentioned, acidity, muscular pain, because of any issues. So sometimes the diagnosis is not made timely, and then they land up into disease. Moreover, sometimes like patients who are bedridden for a long time, or like say for example, recently the COVID also happened where the chances of thrombosis are high. In those situations also these patients remains at risk. So all patients will have some underlying condition which may not have been identified and diagnosed timely, or they may have been ignored or misdiagnosed, and that's why this events leads to. Without underlying cardiac disease, majority of time straightforward cardiac arrest will not happen. It will be a sequelae to something. So also this is a good option when we say about the prevention and good lifestyle modification. So these are important aspects we need to remember, that the stressful life, the use of junk food, the smoking habits, these are all underlying risk factors, and they may precipitate in the form of cardiac arrest. So that's why one has to be very cautious. And since in India, we don't have something called an annual checkup for elderly patients. So that's why some of these diseases are missed and they manifest in the form of a cardiac arrest. So I think based on any symptoms, they should approach the physician, and investigation as required by the physician based on the individual assessment, they needs to be done to diagnose them early and subsequent manage those patients accordingly.
Okay.
I think I'm clear.
Yeah, it's clear, sir. Is
There
it
was
clear?
Yes, sir.
Sir, one more question. What are the most common symptoms of cardiac arrest, sir? Most common.
Cardiac arrest is cardiac arrest. Patient will become unconscious. So that is cardiac arrest. If you're talking about the cardiac disease, the symptoms will be chest pain, right? Or there may be underlying disease which can precipitate them. Like for example, uncontrolled hypertension, uncontrolled diabetes for long standing. Patient will have chest pain. There will be changes in the blood pressures. Patient may have arrhythmias. So these are all precipitating features which can lead to cardiac arrest subsequently if they are not managed on time. The cardiac arrest will manifest as unconsciousness, no confusion. That's the only symptom the patient will have once they have cardiorespiratory arrest. And then if they become unconscious, we have to do CPR as I just mentioned. And if it is for layperson, we have to do a compression only life support. And this needs to be done immediately because the chances of survival decreases by 7 to 10% with each minute. So that's why each one of us should be well versed of doing good quality CPR. And that's why everybody should learn it, and it should be started immediately. Simultaneously call for help and shift the patient to the medical center, so that definitely management can be provided to these patients.
Sir, is CPR is appropriate in surgery?
Sorry, sir, can you repeat the question, please?
CPR is appropriate in any surgery, sir?
CPR can be done in, CPR has to be done, it must be done, in fact, anybody who has cardiac arrest, irrespective of the time, whether during surgery, after surgery, pre-surgery, outside hospital, inside hospital. So once somebody has a cardiac arrest, it has to be done immediately. So there is no contraindication for doing CPR, except when patient is already dead for a long time. And we know that the patient is, there is no chance of doing CPR, which I mentioned on the slide. So all patients should receive CPR once any patient has a witnessed cardiac arrest. Every patient should be given an attempt CPR unless there is some specific reasons for it. For example, say somebody has after a trauma decapitation, right? So I mean, we know that this patient is not going to survive. So that may not be a suitable candidate. Or a patient had a cardiac arrest 12 hours back, 6 hours back, 3 hours back, and their signs of death are there, like rigor mortis. In those situations, only CPR should not be done. But otherwise, any witnessed cardiac arrest, it should be always attempted for patients who otherwise is not a suitable candidate for CPR. So should be attempted at all places.
Okay, sir. Thank you. Thank you, sir. Wonderful information. Sir, thank you very much, sir. Rakesh Garg, sir. And Chakra, sir, would you like to conclude anything, sir?
Nothing. Only thing is, don't wait for the consent of the victim. Because victim is unconscious, he will not be taught.
Sir, bye. Okay, thank you, participants. Sir, I'm extremely thankful to you, sir.
Thank you.
And immediately call for help and go for compression of the chest and nothing else. And
Okay,
don't bother about anything.
Okay, sir. Thank you, Rakesh Garg, sir. A valuable time with us, sir. Thank you very much, sir. I'm extremely thankful, sir.
Thank you.
Thank you, sir. And now we'd like to go for a second session for day 2. Just will give you a break for 15 minutes. You can join after 10 minutes. Thank you.
The music and
Yes. Very good morning. Welcome to second session. Dr. S.P. Lakshminarayan garu. Sir is very expertise person in emergency medicine and critical care. I would like to call upon Dr. Padma Sai to read the profile of S.P. Lakshminarayan sir.
Good morning, everyone. I am very glad to read the profile of Dr. S.P. Lakshminarayan sir. Sir has worked as faculty in Department of Anesthesia and Critical Care in Rangaraya Medical College, Government General Hospital, Kakinada for 19 years. And sir is a American Heart Association certified basic life support and advanced cardiac pulmonary life support instructor since 2014. And sir has presented many papers and chaired many sessions and gave lectures from IMA branches to national level. Thank you, sir. And I now welcome you to continue the session.
Thank you, Padma Sai.
This is a normal ECG. Most of the
Student, please my side. Into link with
if this is fails, we have a backup pacemaker that's all we as a system. Although the heart is from the electrical point of view, it is having only two channels separated by so waves of P, R, T, and rarely seen U. Negative waves are Q and S. And we have the intervals, PR interval, abnormal rhythms, and the acute coronary syndromes. ECG is a representation coronary syndromes. ECG is a representation of the electrical events of the cardiac cycle, and each event has a distinctive waveform. Although the heart has 4 chambers, from the electrical point of view, it is having only 2 chambers, separated by the AV ring. So the events of the biatrial chamber are reflected in the P wave, and the events of the biventricular chamber are reflected in the QRS complex. This is a normal ECG. You have the positive waves of P, R, T, and rarely seen U. Negative waves are Q and S. And we have the intervals, PR interval, QRS duration, QT duration, and of course we have the ST segment. We are not interested in this. SC node is the dominant pacemaker of the heart with an intrinsic rate of 60 to 100 beats per minute. If this fails, we have a backup pacemaker in the form of AV node with an intrinsic rate of 40 to 60 beats per minute. If this also fails, the ventricular cells can act as a backup pacemaker with an intrinsic rate of 20 to 45 beats per minute. This anatomic representation is with reference to the various ECG electrodes. We will look at this later. Now, coming to the normal electrical conduction system of the heart, the impulse starts at the SA node. It is produced there and it is transmitted to the AV node via the internodal pathways. And from there, through the bundle of His, the impulse is conducted to the right and left bundle branches and onwards to the Purkinje fibers. And please note, there are two branches to the left bundle branch, the anterior and the posterior. So we are familiar with the waveforms, and the P wave, as you are all aware, is the wave of the atrial depolarization, and QRS complex is a wave of the complex of the ventricular depolarization because it has positive and negative waves also. And the atrial depolarization is buried in this QRS complex. And then we have the T wave, which is a wave of the ventricular repolarization. Coming to the interpretation of the ECG rhythm strips, the ECG graph paper. The ECG graph paper is divided into squares, large squares, and within the large squares, we have the small squares. And the time is measured on the horizontal line, and voltage is measured on the vertical line, right? Coming to the time interval, each small square represents 0.04 seconds of time across the ECG strip. So naturally, since there are 5 small squares along the ECG strip in a large square, each large square represents 0.2 seconds because 0.04 times 5 is 0.2 seconds. And coming to the height, that is amplitude, I told you it is the voltage. And each small square or each 1 mm height represents 0.1 milliwatt. Okay? Yes. That means 2 large squares, one upon the other, make 1 milliwatt or 1 centimeter. Now, the large squares measure 5 mm in height and width, I told you. So represents time interval of 0.20 seconds. We have already seen that. And so naturally, the large square has 25 small squares in each large square. Okay? So this, we need not worry about this. This has an importance when we calculate the heart rate. Since the ECG paper is moving at a speed of 2.5 centimeters per second, that means 25 millimeters per second. So 25 times 60, that is 60 seconds per minute, it comes to 1500. So this 1500 is important when we calculate the heart rate. Okay, so we will look at that when we calculate the heart rate. Coming to the interpretation of the ECG rhythm strips, we have a 5-step approach here. So we'll be looking at the heart rate, heart rhythm, the P wave, PR interval, and the QRS complex. So atrial rate, we will be counting the number of P waves within 1 minute strip, and ventricular rate within the 1 minute strip of QRS complexes. How to do that, I will be telling you shortly. So there are many ways to calculate the heart rate, but the best way is to calculate the number of small squares between 2 R waves or 2 P waves. Then we will divide 1500 with this. Then you will get the accurate heart rate. Suppose there are 10 small squares between 2 R waves. So then we will divide 1500 with 10. You will get 150. That is the heart rate. So if there are only 5 small squares or only 1 large square between 2 R waves, then we will divide this 1500 with this 5 and you will get 300. 300 is the heart rate. So I told you this 1500 came from the number of small squares that run through the ECG paper in 1 minute at a rate of 25 small squares per second. So 25 times 60 is 15. Okay. So this, let us calculate the rate of this ECG strip. Okay. So we have 4 large squares approximately. Actually, there are lesser. So 1, 2, 3, 4. So 4 times 5 is 20. So you divide 1500 with 20, you will get 75. So that approximately is the heart rate. Okay? Yes. But here actually there are this. Okay? 18 and 83 is the correct heart rate. Right? Okay. Then interpreting the ECG rhythms. Step 2 is the rhythm. Rhythm is a sequential beating of the heart as a result of the generation of electrical impulses. And it could be regular or irregular. So how do we differentiate the regular rhythm from the irregular? That is by measuring the distance between 2 successive R waves. Okay. So first we take 2 R waves and we'll measure the distance between them. And then we'll take another 2 R waves and we will measure the distance between them. And if the intervals vary by less than 0.06 seconds or 1.5 small boxes, because each small square is 0.04, we all know that, then the rhythm is considered regular. So that much of variation is allowed. If it is more than 0.06 seconds or more than 0.15 small boxes, the rhythm is considered to be irregular, right? Yes. Then step 3, P wave. P wave is produced when the left and right atria depolarize. And it is the first deviation from the isoelectric line. It should be rounded and upright. And this pattern is referred to as a sinus rhythm. That is, if a P wave precedes every QRS complex, then all the P waves are of a normal configuration. Okay? And then if the rate is good, within the normal limit of 60 to 100, then we'll call it a sinus rhythm. Okay? That means the SA node is generating this P wave by the atrial depolarization, and that is being conducted to the ventricles and it is causing a normal QRS complex here. Right. Now, after we have detected that it is a sinus rhythm, we'll be asking 5 questions. Are P waves present in the first place? Are P waves occurring regularly? Is there one P wave present for every QRS complex? And are the P waves smooth, rounded, and upright in appearance, or are they inverted? And do all the P waves look similar? So each of it has its own importance. P waves are absent in a ventricular rhythm. P waves may not occur regularly. Okay, so that is also possible. And if the in atrial fibrillation or atrial flutter, the P wave need not be present before every QRS complex, though it is normal. And P waves will vary in configuration depending on the place at which the impulse originated, okay, other than SA. And then if there are multiple foci, then all the P waves will not look similar, okay. Yes. Next is the step 4, PR interval. So this measures the time interval from the onset of atrial contraction to the onset of ventricular contraction. It is measured from the onset of P wave to the onset of the QRS complex, okay, or Q actually. And the normal interval of the PR interval should be 0.12, that means 3 small squares, to 0.20, 5 small squares, or 1 large square, okay. So if it is more than 0.20, then the PR interval is said to be prolonged, and you will see this in heart block, right? So this is how we measure the PR interval, beginning of the P to the beginning of the Q. Then, coming to the PR interval, we'll ask 3 questions. Are the PR intervals greater than 0.20 or less than 0.12? And are the PR intervals consistent across the EKG stream? So we know that in type 2 heart block, the PR intervals are not uniform across all the beats. Okay, they increase successively, right? So that is why we will look for this. Next, we have the most important step 5, the QRS complex. The QRS complex presents depolarization or contraction of the ventricle. And the Q wave is the first negative or downward deflection of this large complex. And R wave is the first upward or positive deflection following the P wave. This is the tallest waveform in a complex. And S wave is the sharp negative or downward deflection that follows the R wave. Okay. So normal interval of the QRS complex is 0.06 to 0.12 seconds. That is 1.5 small squares to 3 small squares max. Okay. Next, this is how we measure the QRS complex from this point to this point. Now, after we have ascertained the QRS complex duration, we'll ask again 3 questions. Are the QRS complexes greater than 0.12 seconds? So then you presume that the impulse is not being generated in the atria. Okay, probably, in all probability, it is generated in the ventricles itself. Then the QRS complex will be broad, more than 0.12 seconds. And are the QRS complexes less than 0.06 seconds? This also can. And are the QRS complexes similar in appearance across the EKG stream? So this can also occur depending upon where the impulse is generated within the ventricle. So now, finally, we have come to the broad interpretation of the ECG rhythm strip with these 5 points. So here, the heart rate is the number of boxes between Rs. So there are 19 spaces. You divide 1500 with 19, you will get 79. Rhythm, regular, okay? RRs are equal here, right? The P waves, there is one P wave preceding every QRS complex. And coming to the PR interval is normal. It is 0.16. And I told you the normal PR interval is 0.12 to 0.2 seconds. Okay, here it is 0.16, quite normal. And the QRS duration is 0.08. So this is also within the normal limit of between 0.06 to 0.12 seconds. So this is very much a sinus rhythm with a normal heart rate. Okay, yes. Now, we can come to the T wave. It is not of much importance in the CPR, the context of CPR, but it suffices to know that it is produced by ventricular repolarization or relaxation, commonly seen as the first upward or positive deflection following the QRS complex. Okay, right. So now there can be artifacts in an ECG rhythm strip, and they can be a result of sources, say electrical waveforms from outside the heart, like the examiners, patient movement, and loose or defective electrodes, or inadequate gel proper grounding, and faulty ECG apparatus. And please note, the ECG is best recorded on batteries rather than the line AC current. Okay. Then we have the rhythms. First, we have the sinus rhythms. So rhythms that originate in the sinoatrial node are sinus rhythms, and there are 5 common variations of a sinus rhythm, of which 4 are very much physiological. Okay, normal sinus rhythm is between 60 to 100. Then we have the sinus bradycardia, less than 60, sinus tachycardia more than 100, sinus arrhythmia between 60 to 100. All of this can be there normally physiologically. And then we have the sinus pause or arrest. Okay. Then coming to the normal sinus rhythm, this is the normal regular rhythm of the heart set by the natural pacemaker of the heart called the sinoatrial node. Okay. So normal cardiac impulses start here and are transmitted to the atria and down to the ventricles. So how do you say that this is a sinus rhythm? First, look at the rate. Okay. So we will see for a wave which is on a beginning of a large square. So this is the nearest. Okay, 1, 2, and almost 3. So that is 15. The rate is around 100. Give or take a few beats. Okay, and there is a P wave preceding every QRS complex. PR interval is normal and QRS complex is narrow. Okay, so this is very much a sinus rhythm. Okay, so the rate is between 60 to 100 beats per minute. The atrial rhythm is regular, ventricular rhythm is regular. See, regular, 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 regular. Okay, and ventricular also regular. Then there is a P wave preceding every QRS complex, and all the P waves are upright and uniform, and the length of the PR interval is within 0.1 to 2.2 seconds, and the QRS complexes, they all look alike, and the duration is between 0.06 to 0.12 seconds. So this is very much a normal sinus rhythm. Next, we have the sinus bradycardia. Here, everything will be as before, like a sinus bradycardia, except that the rate is less. That's all. Okay, the rate is less. How much is the rate? Even less than 50. Okay. There is a P wave preceding every QRS complex, and the PR interval is normal here, just normal. And QRS complex is very much narrow. And all the waves are regular, though they are slow. Okay. The rate is less than 60 beats per minute here. Atrial rhythm is regular, ventricular rhythm is regular. There is a P wave before every QRS complex, and P waves are upright and uniform. And the length of the PR is between 0.1 to 2.2 seconds. QRS complexes, they all look alike. And the length of the QRS complex is within the 0.06 to 0.12 seconds. So this is sinus bradycardia rhythm. Sinus tachycardia is the opposite. Same as before. Only thing is the rate is more. Okay? Right. Next, we have the sinus arrhythmia. So this can occur normally, physiologically, with respirations. Okay? So for inspiration, the rate is more. For expiration, the rate is less. Okay? So here, everything as before. Only thing is the you can't say that the rhythm is regular here. Rhythm is irregular both for the P waves and the QRS complexes. Okay? But since it is within the normal range of 60 to 100, we call it a sinus arrhythmia. Okay? So rate is between 60 to 100. Rhythm is irregular because it varies by more than 0.08 seconds. P wave is there. P wave is upright. So PR interval normal, QRS complex looking normal, and QRS duration is normal. Then we have the atrial rhythms. These are all pathological. This is when a sinoatrial node fails to generate an impulse. Atrial tissues or internodal pathways may initiate an impulse. Okay? Then the patient lands in atrial flutter, atrial fibrillation, supraventricular tachycardia, and premature atrial complexes. Okay? We'll look at these one by one. First, we have the atrial flutter. So atrial flutter is a coordinated rapid beating of the atria. Okay, it is coordinated. Okay, this is compared to the atrial fibrillation where the beating is not coordinated. There is no definite rate which you can calculate in atrial fibrillation. Okay, so and atrial flutter is the second most common tachyarrhythmia after the atrial fibrillation. And the waves, here the heart rate is very rapid. So you can see that it is even less than, more than 300 here rate. Okay. And since the waves are more but coordinated, their appearance is that of the teeth of the saw. So we'll call it sawtooth appearance. It is typical of the flutter waves. So the P waves here are called flutter waves. They are not called P waves here. So how will you diagnose atrial flutter rhythm? The rate is of the atria is 250 to 400. But the ventricular rate is variable. It is not fixed. Why? Because not all the impulses from the atria are conducted to the ventricle, resulting in a QRS complex. No. So the ventricular rate is variable, but the atrial rate is very rapid, 250 to 400. Atrial is regular rate, ventricular may be irregular, that is the rhythm. And normal P waves are absent, only flutter waves are present. And the pattern is a sawtooth pattern, and you can't measure the PR interval because there is no clear-cut P wave here. Okay? And but QRS complexes are very much normal looking. They are narrow and within the duration of 0.06 to 0.12 seconds. Okay? Next. The atrial fibrillation. The most common arrhythmia of the heart. Here, the electrical signal circles uncoordinated contracting. So it could be more than 400 per minute. So there is no action, right? And the ventricles do not receive regular impulses and contract out of rhythm, and the heartbeat becomes uncontrolled and irregular. So here, the impulse that is generated at various parts of the atria is conducted to the ventricles, but not all are conducted, and not in a regular rhythm. So the ventricular beating becomes very irregular. So it is called a irregular beating, or a pulse is called a irregular pulse, which is pathognomonic of atrial fibrillation. Here you can see that there is no clear-cut P wave here, so you can't measure the PR interval. Okay, and the ventricles are very much normal here, so they are narrow within the range of 0.12 to 0.06 to 0.12. Okay, yes. How will you diagnose atrial fibrillation? The rate is about 350 to 400, and the ventricular rate naturally is variable because not all the atrial impulses are conducted to the ventricle. Okay, and the rhythm is very much irregular both for atria and ventricle. P waves are absent and they are replaced by the fibrillatory waves, and PR interval naturally is not discernible, and PR complex and QRS complexes, they very much look alike, and the duration is 0.06 to 0.12 seconds. So the ventricular contraction is quite normal. Only thing is there is no regular rhythm and there is no fixed rate here. Okay, in atrial fibrillation. Now we have the supraventricular tachycardia. So this encompasses all fast dysrhythmias in which heart rate is greater than 150 beats per minute. Here, this differs from the ventricular tachycardia in the sense that the QRS complexes are normal looking. Okay, they are all of them, they look alike. Okay, they are like occur at regular intervals, but at a faster speed. And the duration of the QRS complex is between 0.106 to 0.12. Okay. Only thing is you don't have a P wave, you don't have a PI interval. Okay. Yes. So the atrial rate is 150 to 250. Ventricular rate also is 150 to 250. The rhythm is regular for both atria and ventricles. The P wave is not discernible, and the P wave is hidden in QRS probably. In a low strip, maybe you'll be able to see a P wave. So PR interval is not discernible, but QRS complex, definitely they look alike, all of them. And the duration of the QRS complex is 0.06 to 0.12 seconds. Now, we have come to the ventricular rhythms. Most of the ventricular rhythms are dangerous, okay, starting from the PVCs. So there will be a ventricular rhythm, that is a rhythm generated within the ventricle when the sinoatrial node and the AV junctional tissues fail to generate an impulse. Then the ventricles will assume the role of pacing the heart. So naturally there is an absence of P wave because there is no atrial activity or depolarization. And naturally and most prominently, ventricular rhythms will display a QRS complex that is wide, that is greater than 0.12 seconds, and sometimes bizarre in appearance. Okay, so this is a feature of ventricular rhythm, a rhythm generated within the ventricle. So the most common variations in the ventricular beat is premature ventricular contraction. This is not a rhythm by itself. We'll look at this in detail later. Then there are 8 lethal rhythms. That is the idioventricular rhythm, accelerated idioventricular rhythm, agonal rhythm, ventricular tachycardia or VTAC, ventricular fibrillation or VFib, torsade sleep pointers. This we will not be looking at today. Pulseless electrical activity and asystole or cardiac stance. Okay. So as we go from here to here, it is more dangerous and difficult for you to reverse the patient. Okay. Yes. Now the premature ventricular contractions. PVC is not a rhythm, as I told you, but it's an ectopic beat that arises from an irritable site in the ventricles. So they appear in many different patterns and shapes, but are always wide and bizarre compared to a normal beat. And see, these two are the premature ventricular contractions. They are broad, okay, so they are wide, and in between the two PVCs, the heart beat looks quite normal. There is a P wave preceding every QRS complex. The PR interval is normal. The QRS complex is narrow. Only thing is there is a slight ST elevation here. Okay? Yes. So how do you identify premature ventricular contraction? The atria are usually normal, ventricular usually normal depending on the underlying rhythm. And rhythm depends on the underlying rhythm, irregular during PVCs. And P waves are absent with PVCs. So no question of being uniform or no measurable PVC PR interval. And the QRS complex, normal contractions are normal in between the PVCs. But the PVC tracing is wide and bizarre, more than 0.12 seconds. And it occurs earlier than expected. That's why it's called a premature ventricular contractions. And there are many types of PVCs like this. If a PVC occurs at every other beat, then you call it a ventricular bigeminy. If a PVC occurs every third beat, then we call it trigeminy. If a PVC occurs as every fourth beat, then we call it a quadrigeminy. And if we get two PVCs together, just two, and all like that, then we call it as couplets. And finally, if 3 or more PVCs are there in a row, we'll call it as the runs of ventricular tachycardia. So this is the danger of PVC. PVC, if they are less in number, normally not much of a problem. If they're growing in number, if they are occurring as a bigeminy, trigeminy, quadrigeminy, couplets or runs of ventricular tachycardia, it can degenerate into ventricular tachycardia, and ventricular tachycardia itself can degenerate into ventricular fibrillation. So don't take PVCs lightly. Next, we have the idioventricular rhythm, a rhythm that is generated within the ventricle. So we know the rate is between 20 to 40. Okay. So this is also termed ventricular escape rhythm, considered as a last-ditch effort of the ventricles to try to prevent cardiac standstill. Here the SA node and AV node have failed. That is why ventricle has taken over. So rate, as I told you, is usually between 20 to 40 beats per minute. And cardiac outputs is compromised because there are less number of beats and they are ineffective. Okay. So rhythm is slow, no P wave, wide and bizarre QRS. That is most important. Okay. Yes. So how will you identify idioventricular rhythm? Ventricular rate is ventricular only, 20 to 40, no P waves. The rhythm is regular, no P waves, no PR interval, and the QRS complexes are wide and bizarre with a T wave deflection. See, T wave deflection. Okay, T is inverted, ST is depressed. Next, accelerated idioventricular rhythm. Here everything as before with a idioventricular rhythm. Only thing is the rate is more, that is between 40 to 100 beats per minute. Okay, so naturally here also the cardiac output is compromised and SA node, AV node have already failed. So here you can see that the rate is less than 60, okay, more than 50, and there is a ST elevation, okay, and the QRS complex is very much wide, right? So the rate is ventricular, it is between 41 to 100, rhythm is usually regular, and there is no P wave, no PR interval, and the QRS complex are wide and bizarre with a T wave deflection. Next, we have the agonal rhythm, the dangerous rhythm. This is when the idioventricular rhythm is less than 20 beats or less per minute. This is seen as a last ordered semblance of a heart rhythm when resuscitation efforts are unsuccessful. So, before you get a flat line, you will get this. Okay? So, and then see that the rate is less than 20. Okay? So, coming to the five-step identification of this abnormal rhythm, agonal rhythm, the rate is ventricular, of course, because of the wide complexes. It is less than 20, very slow. Rhythm is usually regular. P waves, no P waves, no PR interval, and wide and bizarre QRS complexes with a T wave deflection. Okay? Next. Then we have the most important ventricular tachycardia. Why is it important? Because left alone, it can degenerate into ventricular fibrillation and then cardiac arrest. Okay? But if detected early and treated with DC shock, this can be reverted to a normal rhythm. Okay? So, this almost always occurs in diseased hearts. It is a rhythm in which 3 or more PVCs arise in sequence at a rate greater than 100 beats per minute. Okay? So, this is what that separates this from accelerated idioventricular rhythm. Okay? The rate is more than 100, then you call it VTAC. And VTAC can occur in short bursts lasting less than 30 seconds. Then it causes few or no symptoms, no problem. But sustained VTAC will be there, it lasts for more than 30 seconds and requires immediate treatment to prevent death. Okay? So VTAC can quickly deteriorate into ventricular fibrillation. So that is a problem here. And it could be monomorphic or polymorphic. All ventricular complexes need not look alike, then it is polymorphic. That is more dangerous. Okay? Yes. Now, this is a classical VTAC. You can see that there is no P wave, so no PR interval. They are broad waves, these are ventricular waves. Rate is very rapid. Okay? So between 300 to 150. So this is quite dangerous. Okay. So how will you identify ventricular tachycardia? The rate is ventricular, of course, between 101 to 250. The rhythm, atrial rhythm is not at all distinguishable. Ventricular rhythm is usually regular. There will not be any P wave before QRS complex, no PR interval, and the QRS complex are wide and distal. Okay. Then we have the ventricular fibrillation. This is not like any contraction at all. This is just some disorganized production of electrical impulses from all over the ventricle. Okay. This could be coarse or fine, and it occurs as a result of multiple weak ectopic foci in the ventricles. There is no coordinated atrial or ventricular contraction, and electrical impulses are initiated by multiple ventricular sites. So impulses are not transmitted through the normal conduction pathway. So there is no meaningful contraction. This is almost like an arrest. If not attended immediately by doing CPR and giving a DC shock, the patient will ultimately die. Okay. So how do you diagnose ventricular fibrillation? It is not discernible. Rhythm is rapid, unorganized, not discernible. No P waves, no PR interval, and no QRS complex. Okay. So you can't call any of these as a QRS complex. Okay. Then we have the systole. It is nothing but a flat line. So there is no rate, atrial or ventricular. So no complexes, no intervals, no nothing. Okay. So no rate, no rhythm, no P waves, no PR interval, and no QRS complex. Since one straight flat line. Okay. This is a systole. And then we have the pulseless electrical activity. This is an interesting rhythm in that you will have a beautiful normal sinus rhythm tracing on the ECG paper. But the heart is not beating and there will not be any pulse out there. So it is the electrical activity without a pulse. Okay. So electricity is working, but the mechanics and pumping are not there. The absence of a palpable pulse and absence of myocardial muscle activity with presence of organized electrical activity on the cardiac monitor. So that is pulseless electrical activity. And the patient is clinically dead despite some type of organized rhythm on monitor. So please note that of the 4 previous rhythms, the asystole and pulseless electrical activity are treated by just CPR. Okay, only compressions and respirations. Whereas VTAC and ventricular fibrillation are treated with DC shock. Okay, so DC shock should not be given with pulseless electrical activity and asystole. Then we have the heart block. So heart block, as you all know, there are 3 degrees. First degree, second degree, third degree, and second degree have Moj 1 and 2. We will not be looking at this with respect to CPR. Now is the time to practice. So I'll be giving you various rhythms and you have to identify them. Okay. First, so very easy to identify. The rate is rapid. The QRS complexes are broad. No P waves. Okay, so naturally it is a ventricular rhythm and it is fast. How fast? It is more than 150. Okay, so less than 300, of course, more than 150. So it is a ventricular tachycardia monomorphic. Okay, monomorphic ventricular tachycardia. So the rate here is 214. So we are unable to determine any rate or rhythm regarding the atrial and the no PR interval. QRS duration is 0.14 seconds. That is more than 0.12 seconds. Okay. Yes. Then we have the ventricular tachycardia here. But here, what is it degenerate into? See, the distance between any 2 QRS complexes is not same as before. Here it is maximum, here it is minimum. So this is atrial fibrillation. This is ventricular tachycardia. Okay. So monomorphic VT to atrial fibrillation. Okay. Yes. Next. What is it here? You can see the flutter waves here. Okay. So that means it is atrial flutter. In addition, what do you have? The QRS complex is very much normal. Okay. But there is depression of the ST segment. So this is atrial flutter with ST depression. Okay. Right. Next. Now, what is the rate here? It is between 175. Okay. So it is a rapid rate and the QRS complexes are wide here. Okay. So is a 52-year-old man, unresponsive, apneic, and pulseless. That means what? Pulseless. That means these contractions are not effective. That means this is an idioventricular rhythm because there is no P wave here. You can see here. Okay, and these are regular, so you can't call it atrial fibrillation. Okay, so no P wave, no PR interval, broad QRS complexes. So this is accelerated idioventricular rhythm. Okay, accelerated idioventricular rhythm here. Okay, now what is this? So here, there are many P waves here. So there is no definite P wave. You can't say that any particular wave is P wave here. That is one thing. And so the atrial rate is there. So no P wave, no PR complexes, no atrial rate. Okay. Now then the ventricles, yes, they are normal duration. Okay. What about the time interval between the QRS complexes? It is less here, it is more here, and it is much more here. That means this is atrial fibrillation. Okay, atrial fibrillation. Right. Next. What is it? It is this 86-year-old woman complaining of chest pain, and the blood pressure is more or less normal. Okay. And let us see. We have a P wave preceding every QRS complex. P wave is there, and a P wave is following, and the QRS complex is narrow, and PR interval is narrow, is normal, and the rate is 60, less than 60. I mean more than 60. So that means it is a normal sinus rhythm. It should be a normal sinus rhythm. Yes, yeah, just 60 beats per minute regular. Okay, so normal sinus rhythm here. Here, it's a rhythmistic from a 52-year-old man with substandard chest pain, has a history of COPD and a mitral valve registration. Blood pressure is 140 or 78. So here you can see there is a P wave preceding every QRS complex, and the rate is regular. Okay, so both atrial and ventricular rates are regular. The PR interval is normal, but only thing is there is a ST segment depression. So you can say that this is a sinus rhythm with ST segment depression. Okay, sinus rhythm with ST segment depression. So this tracing, you can't find any R waves or P waves. So no PR interval, so no rate, no nothing. Okay, this is a flat line. So this is a asystole. Okay, asystole. Now, what is this? From a 1-month-old infant after a 3-minute seizure. So P waves are there preceding every QRS complex. The beat seems to be regular and rhythmic, and the QRS complexes are normal. And the rate is just less than 150. So it is sinus tachycardia. So we know that sinus tachycardia rate less than 160. So that is sinus tachycardia. Then this again, we have seen this strip before. Okay, so there is QRS complexes are normal. You can't find any clear-cut P waves here. So there are multiple P waves here. Okay, so, and the rate is varying from beat to beat. Okay, so this is here it is rapid, here it is less rapid. So this is atrial fibrillation. Okay, atrial fibrillation, uncontrolled. Okay? Uncontrolled. Then we have the 54-year-old man who had a syncopal episode. Okay, so what is the rate here? First, the rate. It's about 60 or even less. Okay, just less than 60. And we have a P wave preceding every QRS complex, and the PR interval is normal. QRS configuration is normal. So this is sinus bradycardia. Okay, this is sinus bradycardia. Then we have this. So here the rate is very rapid. That is less than 150. Okay, I mean more than 150. So around 200 maybe. So P wave cannot be discerned, and QRS complex is very narrow. So this is definitely not a ventricular tachycardia based on the QRS complex configuration. So this must be supraventricular tachycardia. Okay, because there is no clear-cut P wave here. Okay, supraventricular tachycardia, 214 beats per minute, unable to determine atrial rhythm, unable to determine PR interval. Okay, QRS duration is 0.08 seconds. Okay, so this is supraventricular tachycardia. This I'm sure you will be able to identify as a ventricular fibrillation. Okay, no P wave, no QRS complex, no PR interval, no definite fixed rate here. Okay, just a bizarre tracing on the ECG. So this is a ventricular fibrillation. Okay. Now, this is a relationship is from a 6-year-old boy immediately after a seizure. So here, P wave is preceding every QRS complex. QRS complex is normal. PR interval is normal. What is the rate? This is the narrowest complex. It's about 100. Okay, about 100. And this is a so between 75 to 100. So the rate is varying between 75 to 100. So this is since there is a clear-cut P wave here and a normal QRS complex, we can call this a sinus arrhythmia. Sinus arrhythmia, right? 68 to 88 is the minute. This is a, as you can identify, is monomorphic VT. Okay, ventricular tachycardia, because there are regular broad waves. Okay, unlike the ventricular fibrillation. Okay, it's not like this. Okay, so regular, the rate is very rapid, No P wave, no PR interval, and PRS complex is there, but it is very broad and all that. Okay. So, monomorphic ventricular tachycardia. So that brings us to the end of this session on ECG. Thank you. Good afternoon. For the next 1 hour and 15 minutes, I'll be talking
Am I audible, sir? Please join the session at 2 p.m. Thank you, one and all.